written the diagnosis there? You have? You wrote NYHA 0?
There are no symptoms.
Don't
actually.
express like
I
that. There's
didn't write
nothing
it.
like zero.
I have not
Huh?
written NYHA there, sir, because there were no symptoms.
This is NYHA 1. When you
A patient with heart disease, but uh, like there are no symptoms on, like there is no limitation of ordinary physical activity.
Which is class 1, right? In class 1.
Yes, sir.
the keyword there is ordinary physical
Physical
activity
activity.
does not produce symptoms. Whether more than ordinary physical activity produces symptoms
Symptom.
is left unstated.
Yes, sir.
That's probably one limitation.
Limitation.
What are the symptoms included in NYHA?
Symptoms included as chest pain, dyspnea, fatigue, and palpitations. Syncope is not included.
That's the other limit. Hope is not a part. Though hope is a cardinal feature of
Heart disease,
not a
not feature of
included in NYHA.
The patient will ask you, sir, do I need a ICD? What is your explanation? Your answer?
But we'll like to see the imaging features, but
Hmm.
given the strong family history, is more likely to require an ICD.
Strong family history means what?
So there are, both grandparents have died of sudden cardiac death at around the age of 45 to 50.
Here what?
And
Family
he has got one episode of syncope, sir, although no recurrent syncope, but young age. So
What is your next step? Huh? What is your next step?
next step is to do an ECG and echocardiogram. And
No, they have done that. Is done. You see the record done.
yes, sir.
As per the ICD is concerned,
Yes,
Which
sir.
investigation will help you decide little better about ICD?
So the Holter and cardiac MRI, both things will help in determine better.
out
If
of
there
two,
is-
see, he can afford only one investigation.
Then
Of the two, which one you choose?
the cardiac MRI with the scar more than 15%. Probably.
Go through this ECG very quickly. Does it conform to your diagnosis? It doesn't conform.
Yes, sir. It confirms sinus rhythm axis is around 60 degrees with significant left ventricular hypertrophy with strain pattern in V4, V5, V6.
Do you accept the CCG first?
There is a lot of overlap, but
You should have repeated with the half the
with half
voltage.
standardization.
Otherwise, it's very difficult, no?
Any
Lot
left
of
atrial
overlap.
Any left atrial enlargement in this?
Uh, So that V1, V2 is significantly overlapping, but looking at the P waves doesn't look,
Overlapping P wave is overlapping.
Previous.
Left atrial.
sir,
Ah.
that is not there.
The P terminal vector in
What is-
V1.
P1P terminal.
V1 P terminal vector is less than one box only, sir, and even the height is less than one box only. So
Definitely suggestive of, no, left atrial
Suggestive of-
enlargement.
Almost, it looks around one,
One
width
box.
actually looks a little more than one.
Yes,
So what
height
is,
and width.
what is the criterion to say LA?
by that negative, this thing, it is Morris criteria. If the width and height product is more than like 0.04 milliseconds,
No, more
seconds,
than
it comes.
0.03. 0.04 would make it that. This
Yes.
Four will
the
make
width
it.
is, yeah, 0.04. This is, the width is more than, I think it does fulfill the criteria.
Yeah, left atrial
What
enlargement.
is the other commonly used criterion?
The other commonly used criteria is the macros criteria, that is PR and P wave duration.
PER and P wave?
Uh,
What is it? Say it properly.
It is the PR segment
Yes.
divided by your P wave duration.
P by
P
PR
upon PR segment,
not PR interval, and it should be more than,
1.6.
what about the so-called P mitral, the most commonly talked about?
P mitral.
Here, sir,
When would you say P mitral?
it is a biphasic P wave with the second peak taller than the first peak.
No, no.
A bifid.
Bifid, and
Bifid.
what is the most important part of it?
And-
Is the
and the
duration. of the
Second,
P wave.
second P wave
The
duration is
duration of the P wave
more than 3 boxes.
more than 2.5.
2.5.
Is it specific to rheumatic mitral stenosis or it's P mitral is across all?
It's seen in all, not specific.
And usually the second one is bigger. I agree,
Sec-
but that's addition is the duration.
You can get P mitral also constitutive pericarditis. You can get P mitral in constitutive pericarditis also. You are not very specific for
So it is not specific.
Specific.
Which is more sensitive, P mitral or the P terminal vector in V1?
P terminal vector. Chest X-ray, PA view, well exposed, well centralized.
When do you say well exposed?
Sir, the four transverse vertebrae from above should be seen. Whatever is behind the heart, the discs in between the intervertebral discs should not be visible.
So is this well exposed?
overexposed. Sir.
Really overexposed.
Fine, well exposed or adequately exposed?
Yes, sir, the intervertebral disc behind the heart should not be seen, and the upper four transverse vertebrae should be seen.
Okay, continue.
Then the uh, cardiac shadow looks normal in size. There is no cardiomegaly. Cardiothoracic ratio is 0.4 to 0.5. The right heart, the right border of the heart looks normal. There is no RA or RV enlargement. There is the left heart. The apex is formed by the LV, and there is no the left atrial enlargement also. The carina looks acute, less than 70 degrees.
When can the cardiothoracic ratio be more than 0.5 and yet be normal?
If it is a PA film, sir, like it's
Okay.
it's a AP film rather than a
AP
PA film.
film. Because,
thing.
why?
Sir, because now the heart comes more close to the film rather than the source.
Heart comes closer to
Heart-
the
no, sir.
film.
Heart comes, the source will be here. Heart is near
Yeah.
that, so the
So the
shadow of the heart will be
magnification, yeah.
bigger on
What
the
Other condition.
others are in children.
Okay, good.
Then, sir, supine film
Yeah.
taken in ICU.
So that's AP. That's again what you said.
Nice, sir.
And in expiratory film sometimes can also be
Expiratory.
like.
The
LV enlargement, LV apex.
LV type of effect.
Ah,
Sir,
Yeah, it's not very typical of an LV apex, but what is
but
the?
it is
where is-
pointing downwards and it is going into the diaphragm. It is not lifted upwards or pointing upwards.
Any other? Cardiophrenic angle?
Cardiophrenic angle is obtuse.
obtuse.
So it's almost like it go both ways.
Any pulmonary venous hypertension?
Sir, there is cephalization of pulmonary veins. These are grade 2 pulmonary venous hypertension. There is no curly B lines or no hilar pulmonary edema.
From a lower lobe veins are signals.
Yeah, cephalization is when the upper lobe veins are more
Upper lobe are
prominent than the lower
prominent.
one. Right, it should be more prominent. Why does that happen? Give me the explanation for that.
So the cephalization occurs because when there is pulmonary venous hypertension, in the lower lobes, first there is there is edema of the alveolar walls. There is thickening of the interalveolar membrane that leads to decreased oxygen delivery to the capillaries. That hypoxia is a stimulus for pulmonary vasoconstriction. And because this happens in the lower lobe, the upper lobes will get more
So blood gets redirected to the
redirected
upper
to
lobe
the upper
because of
lobes,
vasoconstriction in the lower lobes. Good. Is the pulmonary, I mean, is the aortic knuckle a little prominent? Normally you don't, children is not something you see like this. Older people. Okay,
But sir, the root of the aorta
Next,
doesn't look
echo.
dilated.
fair enough. Let's go to the echo.
Parasternal long axis view showing significant left ventricular hypertrophy. Both the septum and the posterior wall are hypertrophied, almost 30 millimeter, and the LV cavity is small. The LV contractility looks normal. The mitral wall I would like to see other views to know whether there is systolic anterior motion, but structurally,
Say, which is the view that you use for SAM? The view
this
is the
view-
same.
View is the same. I
But
would
you
use a
would like-
M mode or the wall structurally looks. The mobility of the wall looks normal. Left atrium is large probably, sir, but I can't see the posterior part and aorta. So
Definitely enlarged. no?
definitely in the
More than the aorta.
more than the aortic.
Are the papillary muscle, are they hypertrophic?
Yes, sir. Even the posterior papillary muscle is thickened.
So can you say that the mitral valve is normal?
The mitral apparatus, like, can't say that it's actually. The right
we
ventricular
have-
hypertrophy also there. Sir.
Color flow? Yeah. Now,
There is flow turbulence across the LVOT, and at the same time there is mitral regurgitation happening. Uh, mid to late systole part, and like it to be more wider. There is any accompanying, because there are almost the muscle is touching, sir. So whether there is any mid cavity obstruction also.
I think, can we go to the next view? Definitely there is a turbulence across the LVOT.
Yeah, but sir, that doesn't seem to be any mid cavity turbulence. Most likely it is sub
MR is also there. It's almost an eccentric MR.
eccentric MR.
Yeah.
So apical four chamber view showing significant septal hypertrophy. There is asymmetric septal hypertrophy also. The right ventricle side, the free wall doesn't look hypertrophied. Left atrium is definitely enlarged. The five chamber view, there is significant subaortic obstruction. The aortic wall looks normal. No other, like there's no membrane or ridge or anything there. The pressure, the gradient across the LVOT, 47 millimeters of mercury. Severe LVOT also.
Resting
On medicine.
on medicine and resting.
Resting, yes.
Anything about the shape of the envelope?
There is dagger shape of the envelope and the picking, but it is not bifid or anything.
By this,
Very severe.
does it appear to be suitable for a septal ablation?
It's
Percutaneous.
more than 30 millimeter. That is one thing. And
From the
There is-
extent of the hypertrophy?
hypertrophy, more
Is
than
it
30.
suitable or it's? you
Not,
think it's
not suitable. And sir, even the appearance is, there will be scar also. Right? Yes, sir. That will see on MRI, sir, for the scar. Yes, sir.
LV apex. Comment on the LV apex.
Apex is not hypertrophied. There is no aneurysm also.
Anything.
It's not there.
What is the importance of aneurysm?
Sir, aneurysm is one of the risk factors for sudden cardiac death that increases
Apical aneurysm.
apical. That is some trivial TR.
MR. Ah. Yeah. There is an eccentric MR,
Eccentric MR
definitely.
related to
Is the intrinsic MR or the secondary MR?
secondary MR. It is occurring mid to late. It's not, and
SAM.
most likely due to SAMS.
When the eccentric posterior.
The direction is also posterior lateral.
Any want to go for the CMR, is it? Is it done? CMR? Yeah.
RV lateral wall involved. Septum and posterior wall, anterior part, lateral part, all are hypertrophic.
Very much thickened, isn't it?
Yes, sir.
Systolic obliteration from the cavity, no?
Yeah.
Yes, sir.
Most obliterating the
Cavity.
Okay, without-
To the upper.
— 14%. Okay.
With 14% LG with family history of sudden cardiac death and a history of syncope, even though one is a candidate for IC.
What are the other markers of adverse?
One is sarcomeric mutation. The young age,
Not from. I'm
young age, family history, history of recurrent syncope. Then um, episodes of NSVT.
Of sudden death.
Yes, sir. NSVT in the holter. Then on echo, there is massive LVH, more than 30 millimeter. Then there is LV apical aneurysm. LV apical aneurysm. Then on LG, cardiac MI, more than 15%.
History means what? Suppose wife died, sudden cardiac death, not family.
Sir, it is family history in the first degree relative with sudden cardiac death below 45 years.
Yes. Below
Yes.
age also.
Sir, looks normal.
When do you call LV dysfunction in a H2OCM or HCM?
Are you satisfied only with ejection fraction or you like to assess something more?
LV strain also we can do. There will be diastolic dysfunction predominantly.
No, I asked what is the ejection fraction you take as a cutoff.
Sir, for that high risk of sudden cardiac death, that is 50%.
Otherwise,
EF less than 50% is
anything below 50 is
50%.
called as a LV dysfunction. Okay. Most often they will have a diastolic heart failure or whatever. Okay. Thank you. I think, yeah.
I think he's done fairly well. But having said that, two or three things. One is if you get a case of hypertrophic obstructive cardiomyopathy, that too such a typical history where there is virtually no other diagnosis, your examination will be more theoretical than practice. And you know, hypertrophic cardiomyopathy is one of those conditions you need to know everything in greater detail, genetics, treatment options, cath data, because you yourself know there's virtually no differential diagnosis. But you did well, and certainly, possible.
Thanks, Kunal, for the wonderful case. Thank you, all moderators. I request Rita ma'am to give